On to our final session of the day. Again, we're continuing with this theme of considering quality and quality tools that have been developed for the use of the field as a whole, and thinking about how can we apply those to what we're doing here in California. So we have two presenters for this last section. First, John Nicolla, who's the executive director of the Palliative Care Quality Collaborative, the organization that now encompasses what many of you had been familiar with, PCQN, the Palliative Care Quality Network. He's going to talk to us about this patient registry, this national patient registry that we all have an opportunity to participate in. And then we're going to have Jennifer Kennedy come and talk to us about certification. And then after these two presentations, we're going to go into breakout room groups to discuss our perceptions of these tools and how we can all use them. So listen closely and get ready to both continue to ask questions in the chat, and then also to have some time to chat with each other about what goes on here. So we'll kick it off with John from PCQC. John, take it away. Thank you so much.
Hey, thank you. Can y'all hear me?
Yeah.
Wonderful. Thank you all so much for providing me the opportunity to talk with you this afternoon. Well, this afternoon here on the East Coast, I'm in North Carolina. Just before I get started, I was doing a little stalking of the chat earlier when I was listening to some of the earlier presenters, and it's so nice to see some familiar faces with PCQC and such great supporters. I'm very fortunate to have such a powerful community behind us. So just again, thank you all for your time. Yeah, want to talk a little bit about PCQC. I'm going to talk a little bit about some session objectives, and hopefully provide a little bit of time to do some Q&A and talk and discussion during the breakout sessions. But I think we can go ahead and get started. All right. No disclosures. All right, learning outcomes. So upon completing the session, hopefully we'll get out a few different things, but mainly to understand the importance of palliative care programs and collecting quality data, to provide an overview of quality data collection and quality improvement opportunities for palliative care programs by participating in registries such as PCQC. In particular, we're going to talk a little bit about the power of PCQC and national registries to sort of tell a full data story, and then what we can do once we have that story told and how we can learn from one another in the collaborative space, and discussing the value proposition of participating in this registry and how we can help articulate that to stakeholders within your programs. Next slide, please. Session objectives, sort of the same thing. Describe the benefits of the quality registry participation, review advantages and opportunities, comparing data and comparing best practices with peers, really leaning into this idea of breaking down silos and establishing communities for each other within the field, and then discussing services provided by PCQC in assisting palliative care practices and quality measurement, benchmarking, reporting, education. Again, getting into this idea of helping tell a full story, utilizing all of the services at your and resources at your disposal. Next slide, please. All right, this is going to be a little bit of rapid fire, just kind of thinking about quality, thinking about how we define quality, but Institute of Medicine, quality medical care, the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with professional knowledge. Not sure what happened to the font there, but that's sort of how Institute of Medicine sort of defines quality healthcare. Next slide, please. Thinking about IHI and the triple aim, the way that IHA defines it, many of you have probably seen this value equation when it comes to value in healthcare and value a bit more broadly. A lot of business school sort of terminology here, but value is the byproduct of quality over cost. And when we think of IHI and the three-part aim of healthcare reform, we sort of think of three arms of that triangle. The first arm is better health outcomes for patients. The second, and we talked about this, some of the early presenters talked about this, better experience of care. And then the third being lower per capita costs. So kind of thinking of that as a triangle, and then adding kind of a fourth dimension to that sits outside in the way that we think about delivering healthcare with engaged, resilient clinicians. The only way to sort of provide quality is to making sure that the structure of the providers who are assessing and delivering quality care have that support and have the tools to do so. Next slide, please. Thinking about the Institute of Medicine's 6 dimensions of quality. So thinking about quality medicine being safe, being effective, being patient-centered, timely, efficient, and equitable. And on the next slide, you'll see a little bit of how we start thinking about evaluating and assessing areas of quality improvement. So in PCQC, we sort of start with the premise that palliative care is good for patients and families. I think everybody on this call will probably agree. And then from there, we start thinking about, okay, in which ways can we think of the delivery of patient services improved? How can we see that patient experience improve, outcomes, those sort of things? And the first sort of question we think of, could it be better? Then we think, could it be more efficient? Could it be more effective? And how can we make our services a bit more equitable? And I know we've done work with the California Healthcare Foundation, and certainly the work that we've done with them has tied into this concept of how can we make care more equitable amongst patients. Next slide, please. All right. Collecting PC quality data. There's a couple clicks that you can do here for me if you wouldn't mind. Yeah, just keep on going. Thank you. Thank you. Two more. Perfect. Thanks so much. Perfect. Thank you so much. Sorry about the animation. So thinking about kind of the structure or the general foundation of collecting quality data to get to the point where we're collecting patient level data and thinking about process measures and outcome measures, and then how we perform quality improvement off of that data that we're collecting, we sort of have to start back at what is kind of our basic data that we need to collect on our program. How do we set kind of that fundamental stage? And in PCQC, these things are matching or mapping to 3 different areas of membership that we have. But first thing that we think about is collecting basic program information. So asking the question and answering the question, what is your program and where do you provide care? Within our registry, you'll see here that part of the benefit of doing that into our registry, setting up a program profile, is we are heavily informed. PCQC was a legacy project in part with PCQN and CAPC and others. You're able to list yourself on getpalliativecare.org, as our registry now informs that website. So you're visible to your members, you're visible to your patients and your community. Next is collecting program level data. What does your program look like? How is it staffed? How do you operate? Getting things like comparative reports and doing some of the peer comparisons that you've been able to do in the National Palliative Care Registry in that resource in the past, sort of allowing that second level of storytelling. So what's happening at the administrative operational program level. And then third is patient level data. How do we collect patient characteristics, symptoms, patient outcomes, so process within and during clinical encounters. And again, some of the benefit of that obviously is understanding what is happening down at the clinical level, how we're mapping to some of our standards that we see nationally, and then where we can actually identify at the clinical encounter level areas for quality improvement. Next slide, please. All right, why would you do this in a quality collaborative registry? So you're probably thinking to yourself, you can collect all this information, then sort of report it. And then this is sort of where we get into some of the data storytelling. So if you could hit next a couple times for me. Thank you so much. Should have just a couple more clicks, but you can just keep going and I'll just start talking through some of these. So starting in turn of some of this internal analysis. So what you're able to do if you just kind of collect these data and don't participate in a registry is you're able to monitor, optimize service operations. So you can kind of say, hey, this is what we're doing here on a service level locally. We can support standardized assessment and by at least collecting off of national published standards like Measuring What Matters standards, Joint Commission standards, those sort of things, you're able to then go ahead and say, okay, we at least know that we're working off an established sheet of music that's been validated through the field work. Additionally, you're able to sort of demonstrate value locally and secure additional resources, hopefully using some of your internal data. So you can at least say, hey, this is your impact. This is kind of a benchmark of where we are. We've either improved or we've sort of modified some of our practice to account for additional consults, to sort of expand the scope of our practice, those sort of things. But if you only collect those things internally, you're sort of leaving a little bit on the table in terms of how you're able to provide a context, or again, providing a larger scope of the story you're trying to tell. First, demonstrating value locally. If you have external feedback, you're also able to sort of benchmark against others. So you're able to sort of demonstrate what you're able to provide relative to peers. Interpret data, find quality gaps, again, using peer-to-peer connections or peer data comparison reports. You're able to then go ahead and actually see where you're stacking up against peers. Conduct collaborative QI. So talked about the idea of breaking down silos. So using this idea of breaking down silos to then say, we are seeing some gaps in the way that we're delivering care. We really want to ensure that what we're able to do is of best practice. And we don't want to then kind of create that from scratch. We want to lean on some of what others have been doing in our field. And we want to make sure that we're establishing networks with those folks so that we can provide feedback to one another and help build a more, again, going back to equitable and efficient as some of our goals of quality, equitable and efficient processes in delivering care, identifying best practices and benchmarking against peers, and then ensure payment and accountability. And we have members who work with payers. Some of them are, I think, involved in the audience here that sort of work in different contract arrangements and are able to collect standardized data and then demonstrate sort of the results of conducting those standardized assessments on the clinical level to some of their payer partners. Next slide. Okay, so what are we collecting? So on the measure side, talking about program data. So these are things like team disciplines, certifications, sites of care, operational processes. So really thinking of operational, administrative, high level, not digging down into the deep patient kind of characteristics. When we then start digging into patient characteristics, what are some of the items or some of the measures that we might be collecting? Demographic data, who are our patients? What do they look like? What does that blend look like? Reasons for consultations, again, thinking of kind of prompting what happened to get to the consult, processes of care, different, advanced care planning, goals of care, some of those kind of particular assessments that we see common in our assessments. Symptom scores, things like pain, dyspnea, a lot of what you see in ESAS, all of these things that are mapping to measuring what matters in the Joint Commission and the National Quality Forum standards that PCQC is highly informed by, and then some of the disposition work. Again, talked a little bit about standards. First and foremost, starting with National Quality Forum, a lot of what we see in our data dictionary is specifically informed by what was happening in both PCQN and the Global Palliative Care Quality Alliance, two of the sister legacy registries. And a lot of that work and a lot of the data elements were informed by National Quality Forum. The Measuring What Matters work that was published by AHPM, and then the Joint Commission. And part of what we try to help do is provide accreditation data for programs that are participating in that. Reports, program measures, measure scorecard, clinical and summary. So those are available if you go ahead and put in your program data. Those are annual program surveys. You'll always be able to get those out. Those are available now. If you haven't done that for 2020, would recommend doing that. We'll be releasing the 2021 survey soon. Patient, operational, symptom, spiritual, emotional, psychosocial, measuring what matters, and Joint Commission. So this is a kind of a long way of saying that both on the hospital and the community setting, we'll be able to provide you sort of an operational view of what your program looks like, give a deeper dive into how you're managing symptoms and assessing symptoms, provide a little bit of information on kind of the spiritual and emotional psychosocial assessments that are happening. And then down the road, hopefully later on this year, provide a better indicator of how you're meeting Measuring What Matters and Joint Commission accreditation standards. Next slide, please. All right, so we sort of think about at least a National Quality Collaborative sort of in two ways. One is the data. So what are you putting in? What are you getting out of the data, the reporting? How can you use data to tell a story? And then the second is through the collaborative. And we'll talk a little bit more about that in just a second. But first, we want to talk about getting the most from unified registries through data. First is providing sort of benchmarking structural data. So supports requests for resources to ensure access and quality. So these are things, you you can say based off of the peer group that I belong in, according to some of the PCQC reporting, or what we're seeing in the National Palliative Care Registry historic data, this is where we are relative to some of our peers. As you can tell, we are understaffed and we're only able to do a certain capacity based off of the 10,000 hospital admissions. So starting to make a case for either being understaffed or staffed in a different sort of capacity than some of your peers. Helping to drive policy at the state level. So sort of thinking about how you can use some of the report cards that you're seeing and sort of talk with payer partners that you may be working with to say, okay, this is where we are. Again, benchmarking here. This is what our group looks like relative to other programs within the state. And again, talking a little bit about reporting. So then benchmarking clinical data. How do you identify gaps in best practices to empower QI that works? So I think we all sort of understand what quality improvement is fundamentally and what we're trying to accomplish with QI. How do we use the data at the clinical level to really dig into what's happening so that we can, again, get a fuller picture of how we can go about tackling a particular issue? So not only understanding that we might have gaps in a particular patient population, digging into that patient population and seeing that, for instance, of the 55% of a particular cohort of patients that have received advanced care planning, a particular demographic of those looked a certain way versus another. Maybe that might mean we have to focus our educational opportunities on identifying how to sort of close that gap. There's a gap there, and we want to make sure that we are meeting the needs of all of our patients equally and equitably. Demonstrating values to payers, referral sources, and patients. So just kind of understanding, hey, this is the impact of our program, and helping make the case to those different stakeholders. And then finally, a powerful research tool to uncover trends and correlating structures and processes with outcomes. Next slide, please. I think I have two more, trying to go as quick as I can. Getting the most from registries through networking. So again, if we're getting the most out of data through some of those mechanisms, a lot of the benchmarking and data storytelling, how do we then take the data and translate it to quality improvement? We think about that mainly through networking and how we then can provide resources that are tailored to some of the problems that we're seeing amongst the different communities within the collaborative. So again, I've mentioned a couple of times this idea of breaking down silos. I know this is of extreme value in PCQN. It was a value in GPCQA, and we're hearing this more and more. How can we get you all in front of one another to do things like best practice sharing, networking, strategy exchanges, help you learn from one another? How can we help facilitate that? How can how can we use the power of working collectively to really help drive quality improvement? In addition, thinking about national thought leadership, when we see in sort of true quality improvement spirit, when we see a gap or a need, how do we provide the right sort of expertise to then discuss how we sort of tackle that issue, or what are some different approaches of tackling that issue? And then thinking about kind of different research opportunities. How can we use data? How can we use the power of the collaborative to further the field and to advance generalizable knowledge for all of us? And then finally, QI implementation, thinking about, how we kind of go from looking at data, how we're going to structure looking at data together, figuring out a collective sort of issue that we're seeing across the collaborative, and how are we going to put a structure in place to do that? I think I have two more. Next slide, please. And then again, talk a lot about this, won't spend a ton of time, ways to use a national collaborative to demonstrate value. There's a flexibility in collecting data. We try to make it work for what you're doing, making sure that what's being articulated in a national registry is reflective of what's actually happening at the clinical level, and that a form isn't driving, in particular, the patient data work isn't driving what's happening at the clinical consult level to a degree. Internal analysis of data. So able to review your own data, external benchmarking, and again, telling a full picture of storytelling using program, patient, and benchmarking context, that full context of reporting and data to sort of work through a complete story and to advocate for your program and the advancement of your program. Access to resources, again, thinking about the different programs and the different networking opportunities that are present in a collaborative, and how to use the data to do that. And then structure process to analyze using curated resources. Next and final slide. So obviously there are some barriers to participation and how we sort of tried to address some of those issues. First sort of question that we get is getting started. How do we make the case for doing this? It's obviously a time commitment. So we want to make sure that we have buy-in. So what we do is sort of help with collaborative sessions to make the case, provide on-demand resourcing for that kind of work. It's a buy-in of a program and committing to a culture of quality more so than it is just saying, hey, we want to enter data and we help make that case for you. Especially if you're doing patient data entry, if anyone's ever been through BAA legal security work, that can be challenging, especially at larger institutions. So we sort of have a path forward and a roadmap to help with that. Understanding all the costs, the money, time, messaging, all of that, we try to help with that up front. And there, as you hopefully sort of tell, there's a lot of upfront work in getting started. And then the data collection burden, using different multiple avenues of data collection, whether that be manual or taking that and extracting that from the EHR. We all know double data entry and data collection can be burdensome. So we try to alleviate that the best that we can. Clinical implementation, an adaptation of different measures and different instruments that you may be using. If you were to join a national collaborative, we have to work off the same sheet of music. So there might be some training. So best practice sharing, learning from our staff, learning from the community. How do you implement different assessments that you may not have been accustomed to implementing before joining a national registry? Staff training. How do you use the software? How do you use the reports? How do you help tell that story? High touch implementation and continuous team. You'll see us the entire time, on-demand resourcing, that kind of stuff. And then collaboration time commitment. How often do I have to participate? That's flexible, make it work for you. We're working on establishing on-demand content. You know, we're a national registry, so there's time zones that we have to consider and those sort of things anyways. So the more flexible that we make it, I think the more that you'll be able to get out of it. And then we're always available to answer and ask questions. So apologies if I went a little bit over, but that is, I think that's my last slide. Perfect. Thank you.
That's okay, John. Thank you so much. So I think we'll modify our last few minutes here, and Peter and other team members we'll do that in a second. I want to ask you so PCQC, a national registry for palliative care programs, to submit data that helps them appreciate how they're doing in relation to the performance of their peers. One quick question about the data that's collected. Does the demographic data include information about race, ethnicity, language, and housing status? So a lot of the issues that will color the that you see in the patient population that today's attendees work with.
Yeah, so part of sort of our core data set is working with race, ethnicity, language, those sort of elements. We are also, again, working with the California Healthcare Foundation to establish sort of standards in collecting those. So hopefully over the next year or so, we'll have a better idea of kind of standards or a QI manual on how to collect the data that you're seeing in those populations. Hoping that's sort of an output of the work that we're able to sort of to do together. But that is certainly core to what we collect, and it's core to our reporting as well.
Got it. Thank you. All right, John, thank you so much. Really appreciate it. And appreciate the tool as well. PCQC is a great thing.
Yeah,
right.
Thank you all so much.
Jennifer, sorry to start you in a couple minutes late, but you should feel free to take your full 15 minutes. Don't feel like you have to rush. And you're going to be talking to us about one of those items that came up in the survey, both for plans and providers, certification in palliative care. So we asked our providers, were they certified? We asked the plans if they require it. It's a lot of the providers have certification, a minority of the plans require it. So it seemed like it'd be a good idea to get a better sense of what does certification mean and what doesn't it mean? And is this something that we want to consider as providers, getting for our organizations, or as plans requiring it for the folks that we contract with? So please do go ahead and take your full allotment of time, and we'll adjust the last few minutes of the program accordingly.
Gosh, thanks so much for having me, Kathleen. It's always a pleasure to talk about palliative care. And John, you set the stage for me so very well. So I want to thank you for doing that. Next slide. So when we're talking about certification as it relates to palliative care, we're not seeing the main accreditors, which I'll go over in just a moment, really using that word accreditation, save for one. So we're talking about certification because there are no federal palliative care regulations that are currently developed. So accreditation organizations like CHAP and the Joint Commission, ACHC, are going with certification language. So when we talk about certification, this is really the process that you're having objective external peer reviewers look at an organization's compliance if there are any with performance standards that are developed. And there are standards out there, as we know, for palliative care. Really, when we're talking about certification, we're talking about focusing on continuous quality improvement and achievement to the full extent of those quality standards, which in turn then does promote patient care excellence and patient safety, which is what everybody wants, no matter if you are a provider or you are a plan. And certification is that, that stamp of approval, if you will. You get to put that little widget on your website or on your marketing materials when you're going out and about to market your palliative care program, saying that this is the stamp of approval by an objective and trustworthy organization that they've looked at my program and they have vetted it against standardized data. Next slide. So I mentioned the accreditation players in the environment. So of course, there's CHAP, which we have developed our standards based on the National Consensus Project for Quality and Palliative Care. We're using the 4th edition of that to drive our standards. ACHC is another accreditation organization that will certify community-based palliative care, and they also use the same National Consensus Project guidelines for quality of palliative care. And then the Joint Commission certification also they have standards, and they have standards for both inpatient palliative care, and then they also have standards through their home care accreditation, where you can do sort of an add-on, if you will, of a palliative care certification in addition to home care accreditation. Next slide. So there is some eligibility when you look at each of these accreditation organizations as it relates to qualifying or going through their certification process. When you're looking at CHAPs and ACHCs, there needs to be a service of existing existing setting. It could be a physician practice, an ALF facility, a SNF, etc. There needs to be a service of currently accredited hospice or home health, or there can be an independent provider of palliative care. So if any of those providers fit into any of those bullets, they can be eligible for community-based palliative care certification. When we're looking at the Joint Commission, as it relates to their inpatient palliative care, they have to have an organized palliative inpatient program. And as I mentioned before, if an organization wants to go the community-based palliative care route under the Joint Commission, then they first need to go through home care accreditation. Next slide. Well, you're talking about certification with accredited organizations. We're talking about standards of practice. And practice standards are essentially, by definition, reliable statements that are established for judging the quality of practice, service, and education of an organization's performance. And professional practice can change due to a number of things. if there were statutory or regulatory mandates at the federal level, there's always changes that happen with those. But in the absence of those for palliative care, we can take that off the table. There are always advances in technology and economic and market influences that can drive the changing of standards of practice as well. And I think these two are very much applicable to community-based palliative care. Next slide. When we're looking at development and availability of standards for care and patient safety, they serve several purposes. They establish minimum levels of performance. I want to make sure you heard that. They establish minimum levels of performance. Because we do not have regulatory requirements at the federal level for palliative care, we have no foundation or comparison in order to use as the benchmark. Usually standards will go above and beyond minimum regulatory requirements, but we do not have that here. So we're starting out with using things like the Consensus Project guidelines to serve as the foundation for building standards as an accreditation organization. And once there are standards developed, then they will establish consistency and uniformity across many individuals and many organizations that are playing in the sandbox in community-based palliative care. They set that expectation for minimum levels of performance. Next slide. And the good thing about standards of practice and when we're looking at certification is that standards at the accreditation level are really guided by governance and leadership. So I'm really happy that John mentioned a culture of quality, because when we're talking about a culture of quality, it really encompasses and embraces leadership and governance. And healthcare services in accreditation, they include standards and assessment methodology in specific areas of governance and leadership. And when accreditation methodology is built, it evaluates the systems, those primary systems in an organization, and how they work together to make sure that the organization is providing safe care and quality care, and that the leadership is in support of the provision of this type of care, and that there is that culture of quality embedded in everyday practice of the organization. So when you have strong governance and leadership that is embedded in the organization, that really is the driver for a higher performing and sustainable organization that supports things like care excellence and the highest level of patient safety. Next slide. Looking at the benefits and advantages of accreditation or certification in this instance, as we're talking about community-based palliative care, there is positive association with establishment of organizational structures and processes, because you have to meet standards of practice that's going to drive you to not only self-assess what your organization is looking like as it relates to process and structure, but also making sure that you match the standard requirement in all areas of your organization. It's also built into the standard is that there is obviously the promotion of quality and safety cultures along, well, I would say as a larger part of that overall organizational safety and quality culture. This organization who is certified or accredited is always continuously looking for improvement in quality of patient care, and looking at things like professional development of their staff who provide care, and looking at how are they going to improve their business performance and their relationships out in the community so that they can be the best partner ever, no matter if it's a referral source or a plan. So this accreditation really drives an organization's commitment to higher principles of function and gives them that competitive edge. They also receive that formal recognition by peers across the country that they've achieved a certification or an accreditation level. Next slide. Now, with benefits, there come banes, and there are some challenges when you look at accreditation or certification. When an organization is considering taking that leap into certification, it's an investment. It's an investment on a financial basis. It's an investment of staff, and it's an investment for the organization on the whole. And these can be limitations depending on things like the size of the organization, the bandwidth of the organization to take on the work that comes with not only preparing for certification, but maintaining certification. So there are, some of these challenges that go with the consideration of stepping into the arena of accreditation and certification. So you've got to, when you're an organization looking at whether you're going to take the plunge, you need to look at all sides of the cube, if you will, and look at the benefits and weigh them against your challenges and determine, yes, we want to do that, but is the timing right? Do we do it now, or do we ramp up, which you should? You should ramp up to achieving accreditation or certification. You just don't wake up one day and say, let's be certified tomorrow. It is a process. It's not an event. And then maintaining your certification takes resources, financial, staff, and otherwise as well. So I think that not unlike any other business decision that an organization undertakes, this is one that falls into that bucket where you have to weigh the pros and cons in order to make the decision that makes the most sense for you. Next slide. Overall, when we're talking about certification of a program or accreditation of a program, it all revolves around quality and the quality proposition. Provider organizations that voluntarily decide to become certified, they've made that commitment to providing high-level quality palliative care. And that's something that should be attractive to a plan, because this organization has gone above and beyond what they're required to do, which may be nothing if there's nothing in the state regulation, if there's nothing available. Obviously, we know there are no federal regulations available. So it's the status quo. If you decide you want to go above and beyond and seek certification, then you're making an additional commitment to up your quality game and move your needle forward. They've also opted to dedicate those resources to ensure that their patients and their families have an optimal care experience. And also, certification drives the provider to maintain high standards of practice in order to keep that certification in place. Next slide. So before I close out here and we get to the breakout rooms, I wanted to just address on the plan side that it seems to me it would be beneficial for a plan to consider requiring certification of a palliative care provider, because then you know that they've been vetted by an objective peer review organization against a minimum standard of practice, and that organization has met that minimal standard of practice and perhaps has even gone above and beyond it. that's part of the whole quality proposition. You were talking about John and John's program, who's looking at benchmarking performance improvement, but we have to have an entry level, if you will. And I think the certification, in my mind, is the entry level to ensure that you're doing business with providers who know their business of palliative care and have made that quality commitment. So thanks so much, Kathleen. I think I'm at the end of my slide set.
Excellent. Thank you, Jennifer. Hey, a couple of quick questions for you. How many CHAP certified home palliative care programs are there?
We have quite a few, and I know I was going to pull the data for you, and I'm sorry I didn't have a moment to do that. But we have quite a few organizations, and more coming in the door every day as the environment becomes more competitive, and organizations are needing that edge to say, hey, consider me. I've gone through certification. I have this, seal or stamp of approval, if you will, or the widget I can put on my website and my program to say that I meet minimum standards of practice. So
Yeah.
I'll be happy to get that data for you and pass that along if you want to pass it post-conference.
Yeah, that'd be great. And just sort of, is it dozens or hundreds?
Oh, yeah.
Is it hundreds or like up to close to 100 or?
I think we're probably close to 100. I wouldn't say we're putting an S on hundreds, but we're making inroads, if you will.
Great, excellent. Hey, another question is: to get to be CHAP certified, do you have to have board certified physicians, for example? There's a shortage. There's not quite enough to go around for board certification. So if you require certification of specific disciplines in order to be certified as an organization, it could feel like a big impediment, say, to rural programs.
I hear that. And, the shortage issue is just, it's phenomenal for no matter what type of care you're providing these days. But no, we do not require that.
All right, great. Well, thank you so much. Really appreciate it. I think we're all going to break up into small groups now.